Dear Chair, dear audience, let me introduce you my PhD topic, how to optimize the surgical treatment in ulcerative colitis in the next couple minutes. My vision is to provide the best achievable therapy to IBD patients with my supervisor, Pál Miheller, with my SMS, Anett Rancz, with my co-investigator, Hajnal Székely. I'm Laura Tóth, second-year PhD student here at Center for Translational Medicine. I have two ongoing projects. At my first project, we analyzed the effect of obesity on postoperative complications in ulcerative colitis with a systematic review and meta-analysis. I'd like to highlight some important information about the background. The prevalence of ulcerative colitis is around 200 per 100 worldwide. About 1/5 of these patients will need to have colectomy. On the other hand, approximately 1 in 2 adult UC patients are overweight or obese. The effect of obesity on postoperative complications in ulcerative colitis are uncertain. This is why our aim is to investigate the effect of obesity on postoperative complications in ulcerative colitis. We asked the question whether obesity is associated with early and late postoperative complications in ulcerative colitis. We used the PICO framework for that, in what the P was the adult UC patients undergoing colectomy. We compared the obese and the non-obese patient population group, and we were curious about the early and late postoperative complications. We hypothesized that obese patients have more early and late postoperative complications in ulcerative colitis. On this figure, you can see a case of prehabilitation with the blue line and without prehabilitation with the purple line, and the effect of postoperative complications with the green and the orange line. This highlights us the importance of prehabilitation. We did a systematic search to answer our questions in November 2022 in 3-week databases with a search key with 4 domains. One reflects to the disease, one was about the operation, one reflects to the complications, and one focuses on the nutritional status. We found more than 6,000 hits, and at the end of our selection, we found 3 eligible full texts for the analysis. Our first outcome was the length of hospital stay. We included 3 retrospective cohort studies. From them, the first and the second one was propensity score match studies. This would be the cause of the relatively low heterogeneity. We collected means and we collected means from the articles, and we used mean difference as the measure of effect. The overall measure of effect was 0.36 in this case, which reached the level of statistical significance, although it doesn't seem to be clinically relevant. Our second outcome was the total complication rate in the first 30 days after operation. We included the same 3 studies, and we collected event numbers, and we used odds ratio as a measure of effect. The overall odds ratio was 1.08, which is neither statistically significant nor clinically relevant. In case of septic complications, which is the most feared complication type, we used the same 3 studies and the same methodology, and the overall odds ratio was 1.11, which neither statistically significant nor clinically relevant too. Our study has strengths and limitations, of course. This is the first comprehensive data on this topic from high-quality data studies and valuable data sets, and we use rigorous methodology. Although the low number of the included studies, the study design, so there was retrospective cohort studies, and the lack of separate data about different complications and BMI categories limits our analysis. All in all, we conclude that no clinically relevant difference can be can be found between the obese and non-obese patient population, although more investigation is definitely needed regarding to stratified BMI categories, regarding to the long-time complications, and separately on different types of complications. Here you can see our manuscript status. We submitted our manuscripts to the Annals of Gastroenterology or Surgery in March, and we are waiting for response. Now let's move on to the second topic, in that we investigate the surgical outcomes of different pouch techniques in a systematic review and meta-analysis too. Just some important information from the background. The ileal pouch channel anastomosis is a gold standard surgery for ulcerative colitis, but as the time goes by, newer and newer techniques appeared next to the open surgery, the laparoscopic, the robotic, and the transanal ones. So our aim is to compare the effect of different types of approaches on surgical outcomes in ulcerative colitis. And our clinical question was whether open laparoscopic transanal or robotic surgery is associated with fewer postoperative complications after pouch surgery. We used the PICO framework for that, where the P was the patients undergoing proctocolectomy with ileal pouch channel anastomosis. We compared the laparoscopic surgery with the others, and we are searching for early and late postoperative complications. We hypothesized that the transanal and the robotic surgery is associated with fewer complications. If we choose the better approach, we can decrease the potential risk of complications and help the recovery. We did a systematic search in last January with a search key of 4 domains, in that the first domain was the pouch technique, and the second domain reflects the approach. We found more than 2,000 hits. From that, we included 84 eligible articles, and at the citation chasing, we are at the phase of full text selection. In that, we included more than 600 articles. Parallelly with the full text selection of the citation chasing, we started the data extraction, and we did approximately 1/4 of that. Here you can see that we are searching, and we have found information in the articles about the study characteristics, the baseline characteristics, and the comparison groups basic characteristics, but we have found information about the complications related to the operation and other complications that was because of the hospitalization, but not dependent of the type of surgery. And we are searching for other postoperative outcomes, like the length of hospital stay, the length of ELAUs, the duration of the operation, and things like that. Now we don't have results because we are just in the phase of the data extraction. So as a summary, I can say that our first project is under review, and our second project is at the phase of data extraction. As an additional activity, I've presented my first project as an oral presentation, as a poster in English, and as a poster in Hungarian too. And I'm a co-author of Hajnal Székely's projects, from that the first one was published at the Journal of Crohn's and Colitis. And I'd like to thank for your attention with a quote from Confucius: "Our greatest glory is not in never falling, but in rising every time we fall." Thank you for your attention.
Thanks. It's a nice presentation. Congratulations. Questions from the audience? Yep.
Congratulations to your work. I have a question regarding your second project, that you mentioned that during the citation chasing part you found a lot of article, a new one. And do you have a thought that what can be the reason that you don't find these articles with your original search key?
Thank you for your question. I move back, and here you can see that we have a really specific search key at first, but after that, from the 84 eligible articles, they cite a lot of other works, and from that, it is really hard to find the good ones, because it is interesting, but some articles did not define in the title or in the abstract the exact operation type or the exact patient population, and this is why it is hard to decide based on the title and on the abstract that this could be included or not.
Thank you.
Okay. Other question? Yeah? No. Regarding to the first study, so basically you found that this obesity does not have a major impact on the postoperative outcomes. Are you planning to check it also in patients with Crohn's disease and also in patients with obesity plus other concomitant diseases?
Thank you for your question. We focused on the ulcerative colitis because there was a previous meta-analysis which investigated all the patients who had this type of operation, included ulcerative colitis, Crohn's disease, FAP, and this shows the same result, basically, but we would like to specifically can get an answer to the question regarding to the UC patients, and we did not search for specific comorbidities because in one of the included articles they wrote down that they found statistical significant difference regarding to the wound infection, and I think, but we didn't find any information on that maybe this could be, for example, comorbidities, for example, diabetes, but they didn't mention that in the article, as they didn't mention specifically the BMI values, just a mean, and this was an important confounding factor, and this makes hard or analysis. So, in further works, I'd like to, but now we didn't have enough data for that.
And could it depend also on the patient's age? So maybe in obese young or obese elder patients. So do you think that could be also? Does it have a relevance maybe to check it?
We don't have enough data on that too. As I said, that two of the three articles were propensity score match studies, and this is why there were no difference between the ages. But it is important to see that this is not an acute operation. This is planned in early age of the patients because this is to prevent prevent malignancies and reduce the problems. So this is so this usually happens in the early age because this is a planned surgery and this is for prevention.
Yeah, I see. Okay, thank you. Yeah.
Yes, and I probably have a follow-up question regarding the BMI. So looking at your PICO slide, you have one arm where the BMI is more than 30, and the control arm is non-obese BMI less than 30. Does more than 30 include morbid obesity? And does less than 30 includes underweight, maybe anorexia patients as well?
Thank you for your question. We were searching for obese and morbid obese patients differently, but they didn't specify this in the articles. But we saw the mean and the range and the maximum was 38, so maybe they excluded the morbid obese patients, but they didn't write down that in the articles. Yeah, we use this definition according to the WHO. At first, we would like to compare the different definitions of obesity, like on CTs or other measurements, for example, with InBody, but there were no enough data and enough study for that, unfortunately.
Thank you.
Thank you.
Yeah, how about underweight? I mean, if somebody's body mass index is under 20 or so, are there any data on those?
Thank you for your question. There is, to be honest, at first we were curious about every abnormal nutritional status. At first, this was our plan, but in underweight patients, they defined the malnutrition in one study with the albumin, in the other study with the weight, so on. And this is why we can't pull them together. And this is why I think this is why they got different results. For example, in one study they found that there are more leakage, but the other didn't find that, but they defined the underweight or malnourished patients differently. And this is why we can't analyze that.
My other question relates to your second study, since you mentioned robotic surgery. So this is in silico, but as a next step, it could be kind of real, kind of clinical study. So what is the present status of robotic surgery? I mean, I know that this is available for certain kind of procedures, but how about these types of GI procedures?
I worked at the military hospital before my PhD.
Oh, okay, so you are not from surgery.
So,
yeah.
No, I worked at the military hospital at the surgical department, and we didn't have, so I've never experienced robotic surgery, unfortunately. But from 2020, I found more articles in what they use them. So, in centers, they used more and more from the as the time goes by, but I didn't saw it, unfortunately.
So hopefully that is happening.
Yes, I hope so.
Congratulations for your presentation. So, in the first study, you found no difference between the obese and not obese patients. But normally we have a difference. If we talk about wound infection, for instance, there is probably a difference between both. So what is your explanation why you did not find any difference?
We were surprised. I'm waiting for some differences, but we have found one statistical significant difference regarding to the length of hospital stay, but this is why I said that this doesn't seem clinically relevant, because this is just 0.36, which practically means 8 hours, that patients spend more time. This doesn't seem clinically relevant. The others, the total complication rate contains every type of complications, and this is why I think this could be that we didn't find differences. And this was just 3 studies that they included a lot of patients, more than 4,000 patients, but just from one center. And I think that they was aware of this, and they in everyday clinical practice we focuses more on patients who seem more who have more potential, who would have more complications, and this is why I think that could be. And I'm curious about the complications separately, because I think that there would be. But we don't have enough data.
To be honest, in the second study, yes, you tried to work out the difference between different surgical procedures performing an anastomosis, right?
Yes.
Yes. So you have robotic, you have open, and you have minimal invasive techniques.
Yes.
Okay, and you would like to go to work to get the difference between all these 3? Or end up with the same results, there's no difference? What is your idea behind?
Unfortunately, yet I didn't find any RCTs with what we can say that one surgery is superior or inferior than the others. We will see just maybe differences. I'm waiting more difference between the open and the translational, to be honest, because different surgical view and different method, and I think that with laparoscopic we do to be, I don't know if I can say that, but basically we do the same with laparoscopy. We see the same with laparoscopy and with the open one, just the difference how we did the same. But in the translational, we have the so different approach and so different view. I'm waiting for that. But this is just a feeling.
I agree.
Okay. Yep.
Congratulations. Can you tell us, please, what in the daily clinical practice prehabilitation exactly means? And if there's any difference between the outcomes, or which outcomes are going to be better if a patient is prehabilitated or not? Thank you.
I think I didn't mention, but I wrote here that the majority of these operations are elective, so we have time to think about potential risk factors and reduce this, the effect of these factors. For example, there are unmodified or there are factors that we can modify, like the age. But we can modify, for example, the comorbidities, like, for example, if we have a patient with hypertension, we can deal with that before the operation, as we can check the medications, for example, what the patient takes. And
in your first project, as far as I remember, you mentioned that you found propensity score-based papers. Can you please explain what are those? What does it mean?
In the first and in the second study, the centers that did this, that collected the data, searched for patients who had almost the same age, sex. Mostly they excluded the big comorbidities, but the basic comorbidities like hypertension, diabetes, and things like that. And after this, at the first study, they paired the patients. In the second study, they just focused that the mean, let's be almost the same in the two patient groups.